Yeah, live, please, we can start.
Good evening, everyone. Today, on the occasion of Acharya Shushrut Gaurav Din, we are happy to announce that the webinar series themed as Knowledge Fest from the President's Desk under the umbrella of Association of Shalaki CC. I, Dr. Dr. Nutan Saugule, welcoming you all, our respected patron, Dr. Rajesh Pawar sir, our TAS India CC President, Dr. Suvarna Golecha madam, as panelist and as moderator, Dr. Vivek Kanade sir and Dr. Mahesh Kasav sir, and our today's guest speaker, Honorable Dr. Sangeeta Wagh madam, for enlightening us our gray areas on the topic of chemical injury on cornea and treatment. I would like to invite our TAS India President, Dr. Suvarna Golecha madam, for her valuable guidance and introduction about webinar series and upcoming events. Madam.
Thank you, Dr. Nuta. Good evening, everybody. Respected patron, Dr. Puranik sir, late Dr. Parasha sir, Honorable patron, Dr. Rajesh Pawar sir, today's honorable guest speaker, respected Dr. Sangeeta Wagh madam, all members from Central Council of TAS India, like hometown, my home council, that is Maharashtra State Council, all members, all office bearers of all state branches, and dear Shalakis from all over India and postgraduates. It was great wish of TAS CC to start this educational webinar series for Shalakis. TAS CC is thankful to Dr. Kanade sir, Dr. Mahesh Kasav, dear Dr. Amol and Dr. Nutan for their active participation. I am also thankful to entire team, especially MR Dr. Mr. Pathan, Mr. Sunil IT person, Mr. Ashwin, Mr. Raman sir, and very important, respected Dr. Mr. Nikhil Masurkar sir. I am happy to share with you that TAS CC is organizing its national conference hosted by State Branch of Kerala at Thrissur on 10th, 11th and 12th of September 2026. I appeal all of you and TGs to register in huge number and make this event a grand success. Recent discussion with Synergy Man, Dr. Rajendra Lahore, sir, that we are extending the early bird registration date up to 22nd of July by the request of PGs. Today is Dugdha Sharkara Yog. Today is Guru Pushamrut and Gaurav Din of Acharya Sushrutacharya. So it is great coincidence that we are starting our educational webinar series on this auspicious day. हम सुश्रुताचार्य जी की स्तुति की अभी प्रस्तुति सुनेंगे. Mr. Sunil, please.
जय हो आदि शल्य चिकित्सक सुश्रुत महर्षि, प्राणी मात्र के क्लेश निवारक तारण करतासी. जय 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 धीर स्थिरत्वं काशी निवासी, विश्वामित्र कुलोत्पन्नः, विवोदासस्य शिष्योत्तमासी, शल्यतन्त्रोपपन्नः. मुण्डितश्मश्रुश्वेतवसनः स्नात शुचिः सुविचारी, धन्वन्तरी के अनुयायी प्रभु तुम दिव्य तेज मूर्ति. अग्नितप्त यंत्र शस्त्रधरः वैद्य श्रेष्ठ हितकारी, हाथ धरे शस्त्र संदंशक छुरिका करतरी, रणभग्न तिमिर क्लेश निवारक तारण करतासी
वेरी नाइस। हम सबकी ओर से आचार्य सुश्रुताचार्य जी को प्रणाम है। Today, Madam is the opening batsman of our webinar series. We are very thankful to Sangeeta Wag Madam that she accepted our invitation for presenting her lecture. Now, I will hand over the mic to Dr. Amol for introduction of Madam. Thank you.
Good evening, esteemed members of TAS. It is an absolute honor and privilege to introduce our guest speaker for today's TAS webinar, Dr. Sangeeta Wag Madam. Dr. Wag is pioneering corneal surgeon and an eminent leader in the field of ophthalmology, bringing nearly 30 decades of exceptional clinical expertise and academic brilliance. Dr. Wag Madam began her stellar medical journey at the prestigious BJ Medical College, Pune, completing her MBBS in 1986 and her MS in ophthalmology from BJMC and Sassoon General Hospital in 1989. Driven by a passion for corneal disease, she went on to pursue highly specialized world-class training, that is fellowship in cornea from the prestigious L.V. Prasad Eye Institute, Hyderabad in 1990. Then international fellowship in cornea from the University of Rochester, USA in 1993. Eye bank training from TBI Baltimore in 1994. Today, she is cornerstone of advanced ophthalmic care in Pune. She is the founder medical director of Wag Eye Clinic Pune. She is director and corneal surgeon at the Ruby Hall Clinic, where she also heads their eye bank operations. Beyond her thriving clinical practice, Dr. Wag is deeply respected academician and educator. She has contributed extensively to ophthalmic literature with multiple publications in peer-reviewed journals and has authored crucial textbook chapters on corneal disorders. Known for her profound knowledge and clinical insights, she remained one of the most sought-after resource person and keynote speaker at national and international conferences. So, ladies and gentlemen, please join me in welcoming the exceptionally talented and accomplished Dr. Sangeeta Wag Madam to share her insights with us today. Ma'am, the platform is yours. Please go ahead.
Thank you. Am I audible? And
Yes, ma'am.
can
Yes,
you
ma'am.
see the
Yes.
slide?
Yes, ma'am.
I'd like to congratulate the Association of Shalaki on starting this continued medical education, particularly Golecha Madam for asking me to speak. And I think she wanted to know what I would like to speak on. And I thought, since all of us are caregivers and take care of our patients' eyes, I think something that takes priority in our day-to-day practice is trauma and particularly chemical injuries. And I know all of us deal with these during our practice. So I'd like to just share some pearls that I have learned over the last 30 years. And I have no financial interest in any of the products or any of the equipment that has been spoken of. Yeah. So chemical injury is a pure accident and it can be prevented. In fact, this is one of the leading causes of preventable blindness in young people, especially children and in women. We know that chemicals are widely used in the industry, the manufacturing sector, the maintenance, as well as supplies that are used in the pharma and other industries. Agricultural, we know that 80% of our people are in agricultural background and they're pesticides. And you'll see that there are injuries with something like just, ruit's cheekment, that the resin that comes out or the gum that comes out from the plants when they're picking up. Again, domestic cleaning agents, caustic, acid, vinegar, and something like the seeds, crushed seeds of sitafal, we know can cause very severe chemical injuries. Acid splash, it's not just batteries or cleaning agents, but it is used as an assault. And we know of many victims who have been maligned by acid splash injuries. Color, we will see that during some seasons, they come with what looks like chemical injuries. And this is because they use acids as a fixative in the color. So when you have an injury which is out of proportion to the insult, we must suspect that there is something. Then there are in hospital setups, there's ammonia, bleach, peroxide, simple things like Savlon, spirit, ethanol, which can splash. During COVID, we saw a lot of people coming with sanitizer injuries. So this is also a form of a chemical. What we have to remember is in addition to the chemical, there can be a mechanical and thermal element to the injury, because sometimes the chemical explosion that occurs also has a forceful impact, and the heat generated can also cause the thermal injury. So we need to look at all the aspects of an injury. Carelessness of adults, we know it is like an epidemic, the Tsuna injury, where the young children are affected. So these are the various agents. I'll not repeat because it's already covered. Acid burns, we know the prognosis is better than alkali, but it can cause extensive limbal cell loss. It can cause the same injuries like ischemia, ulceration. It can penetrate and cause anterior chamber reaction like iritis, lens opacification, and secondary glaucoma is also known. The most toxic is sulfuric acid, but hydrofluoric acid is also known to penetrate. Likewise, ammonia can. So what happens in an acid injury is there is denaturation or coagulation of the proteins. This causes precipitation and formation of an eschar and a rapid shrinkage of the collagen. Because there is precipitation, the degree of penetration of an acid compared to an alkali is much less. But because of the collagen shrinkage, you can get an acute and very high rise in intraocular pressure, which is often not noticed while treating these patients. In alkaline injuries, alkalis, I think ammonium hydroxide is the worst. Then you have sodium hydroxide, potassium hydroxide. And in children and young adults, we see that they're often more affected because of the cleaning agents, or, if they're carelessly kept and the children get reach of it, they can be affected more than the male adults. Alkaline injuries, we know that they bind the glucosaminoglycans and cause saponification or liquefaction or lysis of the cell walls. And that is why it causes more tissue damage. Once the tissue is damaged, the antigens are altered and exposed to the immune system. They bring in a lot of inflammatory cells, and there's release of the like leukotrienes and inflammatory mediators. And this perpetuates the stromal melt and the cascade goes on. So here, utilizing calcium can stop and block this cascade and reduce the amount of injury, which we'll look at later on. So chemical injury is an emergency, and a patient coming in should be taken as priority. And it can be the most devastating sequelae, leading to loss of vision because of limbal cell deficiency, glaucoma, and even corneal melting. So assessing the patient, assessing the degree of the injury has a lot of bearing in the treatment, and you can prevent the tragic consequences. So actually in my screen, the picture is missing, but can you all see this?
Yes.
Yes, madam.
We look at the eyelids and the eyelashes. If there are burnt, then you know that there is a thermal element to this injury. You assess the amount of the lids that are damaged, the conjunctiva, the corneal epithelium, look for corneal edema. Try to recognize areas of limbal ischemia, which I'll show you in the next slides, how to see. Also, you see whether the visualization of the anterior chamber is proper or not. If you cannot see the iris, that means there is an intense fibrinous reaction, and this has to be controlled differently. Sometimes you can have, if the patient comes in a few days later, you may even see that the lens has gone cataractous. Always do a digital tonometry to see how hard the eye is, because that will tell you the intraocular pressure. Because sometimes you can get the ocular surface to stabilize, but the vision is lost due to glaucoma, which has been missed. So we should always keep it at the back of our mind. There are many classifications for treatment of chemical injuries, but I think in today's day, what is the most relevant one is what is taught by Professor Dua. So he has looked at the limbal involvement, the conjunctival amount of extent of conjunctival ischemia, and then you draw analog scale and it is graded from 1 to 6. So 1 where there is no injury, you can just get a splash without epithelium being damaged. And then you see the number of clock hours of limbal involvement, and you see how much percentage of the conjunctiva is ischemic from 0 to 100%. And then, so like a grade 3 will have between 3 to 6 clock hours and 30 to 50% of the conjunctival ischemia, and you note it down as 3 to 6, say 3 clock hours by 30%. So it'll be 3 by 30. And that comes to a grade 3. So sometimes, like if you see the picture on the left here, this would otherwise look like a very severe injury. But if you look, this epithelium, this limbus is spared, and here only 3 clock hours is affected, and only about 20% of this whole conjunctiva is ischemic. So this is like a grade 2. As against this, if you see on the right side, there is extensive, more than 50% of the conjunctiva is affected. The limbus, almost 9 clock hours is affected. So this is like a class 5 or a very severe form. Another thing one needs to keep in mind is the appearance of the cornea is very deceptive. You will see a clean cornea and you'll think that this patient is absolutely normal. Actually, in fact, this is a total epithelial defect. And if you look at the conjunctiva, this is going to be the telltale of the extent of ischemia. Here you can see there is blanching of the blood vessels, which tells you this is ischemic. So ischemia is a very ominous sign. And we need to remember, here you can see these are all thrombosed capillaries, and soon this will also become ischemic. So these are very severe injuries. Now, something that looks like this looks like a porcelain eye. You can already see a melt here, and this is a very poor prognosis. If a patient comes with a melt like this and thinning again, this is a very poor prognosis. Why it's important to know is, see, everybody will want a miracle. Patient, when they come to you, the first question the parents will say, or the patient's relatives will say, is the eye saved? Will he get the vision back? It's not very severe, no doctor. So at that point, you have to document and explain to them what the prognosis is, because that will depend on the severity of the injury. Now, tsuna we know is a very bad menace. It's all over the country, and it does not see any class. You have the rural and the urban, the rich and the poor, all are affected by this. And it is just our carelessness. So it is used besides industry, besides plastering. I think the worst menace is the tobacco that is eaten. We know that it is sold in the form of thin plastic packets. When I was growing up, it used to be, you had to buy it and put in a steel container. That is what I would see, people using. Later on, it came into plastic dibbies. The dibby, you could shut the lid tight. Now, the plastic pouches have become a big menace, and children find it very attractive because the liquid moves. So they try to press it, and that is when it squirts into the eye. Now, this is more notorious, or I think it is the worst of the injuries, because it forms calcium soaps, and you can see it penetrates the stroma and sometimes even into the anterior chamber. It causes very severe, intense vascularization, scarring, and cicatrization. And then there are multiple surgeries that are required. So here you can see this is total ischemia, and in this part you will see that the lime has actually penetrated into the cornea. Now, this patient, even if he recovers, his visual axis is affected, and then eventually he'll need a corneal transplant. Patient has to be attended on priority. You have to note down whether it's an accident or assault, and if it is, then it has to be a MLC case. Consent for treatment should be taken not just from the patient, but from the attendant, because many times if both eyes are splashed, it is not a valid consent when you take it from the patient. You have to note the nature of the injury and assess the injury, and emergency treatment should be initiated immediately. So you anesthetize the eye. First is pain relief. Give the patient a painkiller, anesthetize the eye so that he will cooperate. Do copious irrigation for half an hour to 1 hour with whatever is the most sterile solution you have. If it's at the site of the accident, you can use drinking water or mineral water. In the clinics, we use sterile normal saline. Earlier, they used to teach us that you neutralize the pH, but now we don't do any of that. You remove whatever the visible particles. In Suna or lime burns, you can use EDTA to neutralize and dissolve the lime. If the pressure is very high, you don't hesitate. Do a 26 gauge paracentesis to release the pressure. It will also neutralize the pH because whatever acid or alkali has gone in will get neutralized. And of course, children, we keep NBM till further notice. You can use EDTA to chelate the lime. The simplest is you take the vacutainers in which you draw blood. You can take 3 of them, swirl the same 2 ml of saline in each of this. So you draw it from one, put it in the second, take it out from second, put it in the third. It will give you the concentration of 1.8 EDTA. And you use that to rinse the ocular surface. It will immediately neutralize the lime. Now, what is important to know is that the first action when something splashes in the eyes, you squeeze your eye tight. In this instance, what happens is the lime goes into the upper fornix. So when you see with just holding the lids, you will miss it. So always try to do a double eversion. And even if the child doesn't allow, you hold him down, anesthetize. What we do is sweep a sterile bud with ointment through the upper fornix. And I will just share a video. Is it playing?
Yes, ma'am.
So I'll try to go a little fast. So sometimes, the lime has become solid. In that instance, you have to cut it out and take out all the visible lime because it will continue to cause inflammation at a later date. And this is what happens. If the lime remains in the upper fornix, the entire upper limbus is gone and you have dense symblifera like this. This you need the primary repair and then followed by what is for vision restoration. Now, amniotic membrane is a very important tool. You can use freeze-dried or fresh amniotic membrane. And this reduces the inflammatory cells that come. It facilitates the epithelialization. It maintains the normal cells which are still preserved and reduces the amount of scarring, adhesion, and vascularization. These are all the benefits. I will not go into detail, but basically it restores the ocular surface by reducing the scarring and the vascularization. And you can get it and keep it in your deep freeze and use it as an emergency. You can get freeze-dried forms, you can get fresh. And I think there are many institutes now that are supplying it. But a very simple thing is using what is called the amserter. It's a very simple device. There are just 2 rings. And it is a sutureless way of putting amniotic membrane. Here it was devised by Dr. Bhaskar Ray Chaudhary from Kolkata, but he primarily introduced it for Stephen Johnson because you can do it bedside in the ICU. I'll just show this brief step. This is the first ring. You open it out, then you put the amniotic membrane, and then you sandwich it with a second ring. And then like a contact lens, you literally have to just slide this on the cornea. And then you can use the remaining extra amniotic membrane to line the inner sides of the upper lids right up to the lid margins. So these are the various uses, but it can also be used in acute chemical. What are the alternatives? Suppose you do not have amniotic membrane, you can undermine the conjunctiva and pull up the tenons and suture it to the limbus. Or you can do a Gunderson's flap where you mobilize the conjunctiva, pull it down and suture it onto the limbus. The idea is to cover the raw surface and bring blood vessels in so that you convert the necrotic ischemic area into a healthy vascularized. So the more bleeding you get, the better it is. Now this one also I will just, so this is what you do. You undermine the conjunctiva, the whole thing retracts. So you have to separate the conjunctiva from the tenons, make it free, and then you pull it up and literally you have to tuck it and suture it along the limbus. So this is how you just bring it up and you can just pass it through the episclera and cover the hole. Then this will bring the blood vessels and healing and prevent melting and necrosis of the sclera. So the other things that we can use are collagenase inhibitors. Doxycycline is a very important agent. Topical steroids have to be used in the first 10 to 15 days to reduce the amount of inflammation. But if the epithelialization does not take place beyond the second week, you have to taper down the steroids because otherwise it can worsen the melt. We give cycloplegics for the, so steroids are also required for the iritis, cycloplegics to relieve the pain, and a lot of lubrication, and remember the anti-glaucoma medication once you feel what the pressure is. So EDTA, like I told, is a very good tool. You can get acetylcysteine, that is in the form of the injection mucomix. You just dilute it to 20% and you can give it as drops to be put every 2 hours. Topical ascorbate is again a very useful thing which you make with the injectable ascorbate. We had done a very brief study with some time back where we compared the use of ascorbate and ascorbate with amniotic membrane, and we were pleasantly surprised to find that the group which had only ascorbate epithelialized a little faster than the one with the amniotic membrane. So basically, what is the use? If you don't have amniotic membrane, using the ascorbate can also give you a good epithelialization provided no other complication happens. So rise in intraocular pressure happens bimodal initially because of shrinkage and later on because of the inflammation that happens. So this has to be taken care of because once you have a scarred conjunctiva, doing glaucoma surgery is very, very difficult. So steroids in the acute phase have to be started locally as well as systemic. You give it for the first 10 days to prevent the migration of inflammatory cells. After day 10, it has to be given very judiciously, otherwise it can worsen the melt. With steroids, you can give prednisolone acetate or dexamethasone because these penetrate better. Oral steroids are given anywhere from 2 to 4 weeks till the eye becomes quiet. So reparative phase starts from day 7 to day 14 to 21, where blood vessels come in and they bring in all the nutrients, proteins, but the fibroblasts also come in, and fibroblasts are the ones that are going to cause the scarring. So the corneal ulceration stops once the epithelium grows in. So it's a competition between the epithelium growing in, the healthy cells from the limbus, as well as the blood vessels. And this is the basis of what Professor Dua said as so superficial sequential keratectomy. So when you see the conjunctiva vessels growing in and the epithelium is not yet covered, you scrape it back with a 15-number blade and repeat it such you can prevent vascularization. Like here, if the blood vessels are growing in faster than this sliding, you just keep scraping those blood vessels back till you get a complete epithelialization. And that way you can avoid semlephrons. So this is what, here, like I said, it's a race between this epithelium growing down and these blood vessels. So if we had picked this up in the earlier stages, we could have pushed it back and then you would have had the corneal epithelium sliding over. So steroids are used. The role of anti-VEGF is doubtful, but you can do fine needle diathermy in stromal vessels with a 10-on needle. You can use a unipolar cautery and you just put the needle inside. You can see this blood vessel. You pass the 10-on needle and apply the lowest current of 0.5 and you will get blanching here. And eventually this blood vessel will shrink. So reducing the vascularization is important to get a good outcome of the corneal transplant eventually, or to also prevent the scarring. In late phases, the parents will say, when will he see? When will you do the transplant? So you just have to tell them to wait patiently. The scarring may take place over 6 months. It may take place over 1 year. Only when you have sequential follow-up that the condition has remained the same, that is the time you go in.
21 hours.
So this picture can end up like this, but we can prevent it if we bring timely measures like the ones which I told earlier. Preoperative ultrasound and wherever possible an anterior segment OCT to get to know what type of cells are there is important. Look at the intraocular pressure, that will tell you about the IOP, and also look for the Schirmer's. If the Schirmer's is 0 because of cicatrization, scarring of the lacrimal gland or the outlets, then any reconstruction is going to fail. So these are the various, what is most important is to restore the limbus and the stem cells. You can have autografts, that is the cultured limbal autograft, or you can have the expanded cells in the form of SLET or the cultured limbal epithelial transplants. And allografts are used when you have bilateral chemical injuries. So you can use it from a living related donor or a cadaveric donor, but these need systemic immunosuppression lifelong. So what is important before doing a site restoring surgery, we must restore the corneal phenotype. And this is done by doing the limbal cell transplant. Now, this was initiated and promoted by Dr. Sangman, who is a close friend. So basically, you harvest limbal cells from the good eye. This is in case of unilateral injuries. Before that, you have removed the entire pannus 360 degrees and got a clear bed. Then you divide this into small bits, as small as possible. And then you place an amniotic membrane with glue. Here we have cauterized all the blood vessels. And here you put glue, and over the glue, you put the amniotic membrane. And then on the membrane, you put these small bits of limbal cells tissues. These islands you put all over. There's another technique which Dr. Datar in Pune has also tried, where you put the limbal explants and you cover it with the amniotic membrane. So we don't know, because this amniotic membrane scaffold eventually gets replaced. So here you can see there's almost a 360-degree knockoff. Here you've done a limbal cell transplant. You can see these islands which are there. Here you can see the amniotic membrane. This is fresh. And this is eventually, this is the type of restoration of the ocular surface. And you'll be surprised, over months and years, it clears a lot, and you may even be able to restore good vision. So what happens to those where you cannot do a limbal cell transplant, where you cannot restore the vision with just the slit? You go in for either a partial thickness DALC, depending on the depth of the scarring, or you can go and do a full thickness penetrating keratoplasty, or you can do a K-Pro. Now here, this child, he had come with a Tsuna injury. We had done a slit, and eventually I could do a DALC. So here I preferred a DALC because his endothelium was retained and the stroma was quite clear after I had removed the pannus and we had done the slit. Now this little girl, she is like almost my concluding case. She again, her mother practices Unani medicine, and she had got Tsuna home for her mother-in-law who had very severe osteoporosis. This child found the jar and then it got splashed. And we've done about 6 or 7 procedures, including a slit. Then besides the slit, she developed symblephrons in the upper lower lid. We removed those. Finally, I also had to give a 5FU to prevent those vessels from growing onto the cornea. And today she's a college-going girl. But this was when she was 8 years old. And so you can even teach an 8-year-old, and we could rehabilitate her. She has 6'12", 6'9" vision, college going, and she says she wants to be an ophthalmologist. So that was the biggest success. From when she got an injury at the age of 5 to now, she's age of 21, seeking admission in a medical college. And I think this story is worth all the effort and all the teaching and learning that I have had in the last 30 years. So we must remember that this is an acute emergency and we must give it our full attention. And we have to hold the hand of the family for years to come, because we know it doesn't stop at one surgery like a cataract or a refractive procedure. There are multiple procedures. Many times, some of them run out of money. They have to sell their property and land. And this is where we look at beneficiaries, philanthropists to help. And that is how we try to rehabilitate them so that they can achieve a useful future. Thank you. I'm happy to answer any questions.
Thank you, madam.
Thank you, ma'am. Thank you. Dr. Nutan?
Yes, sir. I would like to request our respected patron, Dr. Rajesh Pawar, sir, to embrace us with his knowledgeful thoughts on this topic. Sir? Pawar, sir?
Oh, yes, I'm here. First of all, let me thank Dr. Sangeeta Madam for this elaboration. The topic is very vast, but she has very nicely covered it. What is the exact emergency in that all chemical injuries and how it is to be addressed very nicely. Uh, as rightly introduced in the beginning by Dr. Amol, Dr. Sangeeta Madam is not only an academician, she bears a social responsibility also. You might remember on TV channel, the Ramayana series was there. I think in present generation, I don't know whether they have
They
noticed
do
that
know Ramayana
or
series.
seen that Ramayana series or not. But all arrowhead injuries they used to occur in those when that series was on telecast. So Dr. Sangeeta and other people from Pune they took the lead. They approached the state government that time, and even as rightly she told, the tuna which was usually sold in pouch, a
Yes.
plastic pouch, that was converted into a small plastic dabbi. So this is not only the academician's work; it is she has got the social responsibility also, and definitely with the uh, putting her efforts in iBanking all over India. She is doing a great job. I must thank on behalf of Association of Shalaki, Madam. Thank you very much. You are just a genius. Nothing else. Thank you very
Where
much.
In fact, thank you, sir, for your support, because in the beginning, when I was trying to establish myself as a corneal surgeon, there were, without taking names, there were people who were very cynical and apprehensive. They said, what is cornea? What is specialty? But, I had support like Pawar sir, he would send his patients, we would discuss them, and we would together treat patients. So that is how I got my platform, and I could practice cornea as a subspecialty, because I think I was one of the first people who came in with a formal fellowship, and it was difficult to prove that I have something different to offer. So it's only with support of people like Jawar sir, Dr. Rajesh Pawar sir, Dr. Kanade and Kanade madam, that I was able to at least establish an identity for myself.
Yeah,
So I'm grateful for that, sir.
yeah. Thank you very much.
great.
Thank you, madam. I would like to request to our today's moderator, Dr. Vivek Kanade sir and Dr. Mahesh Kasav sir for their expert opinion on today's topic, please.
Well, thank you, madam. This was a very nice elaborative lecture. As far as general ophthalmologist is concerned, can I ask you one question?
Yes, sir.
That what is the take-home message as a first basic need of the chemical burn injury? And before referring this patient to the eye bank, what should, as a general ophthalmologist, should prefer? Washing, padding, and everything, and explaining to the relatives of the patient. What you will suggest?
So that's exactly. So first thing is that we have to just inform the family that they realize that it is an emergency, because they bring the child in an emergency or a patient industrial accident. So at that time, we have to explain to them what we are going to do and what we have a concrete plan. Because if we show that we are in panic, sometimes you get with bilateral and then, simple expressions like "Are Bapre,"
Oh,
that 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 really puts off the patient, the family, they go into depression. So first thing you have to tell them is, okay, you're not the first person it has happened to. We have treated cases like this, and we have hope that we'll be able to get your patient better. And then we have to explain to them that we are going to first do emergency treatment, first aid, take him, first is to give an analgesic, because the patient is in severe pain and agony, and then you cannot examine properly, you cannot treat him. So you give an analgesic, you give, of course, if it is a child and you have to keep nil by mouth, you cannot give. But otherwise, for adults, we first give a painkiller. We put a drop of paracaine in both the eyes. Then only the patient will have allowed you to examine.
Yes.
Then we do a thorough wash. Then we'll put an ointment and let them be seated or lying down. Then take the family and tell them that we have examined the patient. This is what it is. This is the grade. This is the severity. And this is the treatment that we'll be needing. Now, I used to find a lot of difficulty in convincing patients for an acute phase amniotic membrane graft. So they will say, Doctor, drop ne nahi ka honar, can you not give tablets? Do we have to do a surgery? We'll have to give anesthesia. So at that point, we explain that if we want to limit the amount of the damage, then we have to cover the surface. The simile I give them is, suppose a patient comes with burns. What do you do? So I tell them this amniotic membrane is like a bandage or a dressing which preserves the tissue. And like we do it for burns to reduce the scarring, to prevent the fluid loss, here also we are putting this thin membrane to protect the surface from further damage. Once they agree, then we do the amniotic membrane graft. And then we have to explain to them that this will not stop the scarring, but it will reduce the extent of scarring. He may or may not need further treatment in the form of different surgery. So we
Yes.
give them a clear-cut idea on what the whole picture is. And then step by step, the acceptance comes. First, when they see that the patient is comfortable, the pain is less, then they will cooperate with you for the further treatment.
Yes. Another thing, madam, as compared with the tarsorrhaphy, amniotic membrane is a very nice tool in our hands. Another thing is that Chuna, Ruiza cheek, and one more thing, there is what we can see is Fevicol or Feviquick that goes into the eye, and patient comes to you rushing, Feviquick in the eye. That is also chemical injury. Okay, thank you. Is anybody anybody wants to ask the questions?
So there is one thing which I had, these are just cases which I have treated as emergencies, where there was an industrial accident where some chemical had splashed in the patient's eye, and he also had facial burns. So I was called to another hospital and I was asked to come to see. And when I looked, there was this yellowish brown layer which had covered both his cornea. So they asked me, can you not do it here? So I said, see, the patient also had burns on his face. The lips were swollen. I said, see, suppose something happens to him and I'm doing it here, it will be a bit of a problem because he may get stridor, he may get laryngeal edema because there were some fumes which he has also breathed in. So my just sixth sense told me that I should not do this treatment bedside. So we shifted the patient to Ruby Hall, and the anesthetist was just waiting. And I'm slowly with paracaine and with the buds and all, I could peel it off like a stamp paper, literally, that plastic.
Oh,
And yes, and then what happened is suddenly the patient started getting breathless. He got tachycardia, bradycardia. What had happened? He developed full edema in his larynx. At that point, they had to do a tracheostomy and somehow managed to. Young patient, he was hardly 28. So that's why I say that we should assess the patient as a whole. It may be just the facial burns, but suppose I had done bedside and gone away and the patient had got laryngeal edema and died, what would they have said? डॉक्टरांनी डोळ्याचं ऑपरेशन केलं आणि आमचा patient. So, you have to be intuitive. We want to help. Means I felt that why with the ambulance I'm taking patient to Rubiwal. But then later on I realized, what if I had just done it there, or while doing, if something had happened to the patient, he's your responsibility. And only the surgeon will be blamed for any of the consequence.
yes.
So we have to see the patient as a whole and see whether he is in our purview or does he have to be under some multi-speciality care. Again, industrial accidents, many times we treat, but we do not take an informed consent from normally if some attendant comes from the PR department or whatever. And then, what happens? They will come 7 years later with a notice for you to appear in court because compensation has to be given because of loss of vision. Then they ask you, when you first saw, what was the clinical picture? So these cases, you have to preserve the record for not 10 years, 50, your whole career. I have been called to places like Parbani, Nanded by the court 8 years after the accident, where acid splash happened, patient lost his eye. He is asking company for compensation. You are the first person who saw. They want to know, what? Do you have your document? You can fight only with your case paper.
Yes. Any participant? Kasav?
Thank you, madam, for your inputs. I have a small few doubts. What would be a role of systemic medication of vitamin C or doxycycline, and what would be the good time which patient we should consider that?
Yeah, that's an excellent question. I had just highlighted very briefly in fact, that study which we did, in both groups, we gave vitamin C because vitamin C is supposed to stabilize the collagen. Doxycycline has also anti-collagenase activity. So till the epithelium heals, we give doxycycline. You can give it up to 2 to 3 weeks, but just keeping in mind that there may be GI side effects. So you get doxycycline with lactobacillus. That combination is safe to give. You give BD on the first day and then OD thereafter. Just make sure that the patient is over 16 years old so that it doesn't affect the dentition. And the vitamin C we give anywhere from 500 to 1 gram 3 times a day till epithelialization. And the topical ascorbate was also made with the injection ascorbate, which we have given locally like every 2 hourly to begin with, then taper down and keep putting it till the epithelium heals. Again, acetylcysteine is mucomix. It prevents the melting of the tissues, and that can also be given. So these 3, 4 things you can give simultaneously to stabilize the collagen. As far as the systemic treatment, other treatment goes is oral steroids, because after day 10 we cannot give very strong steroids, because suppose there is thinning and melting is going to get worse. So you give oral steroids. Sometimes if it's very intense, there's too much edema, you can even give 500 mg of Solumedrol IV, and then you start giving oral steroids 1 mg per kg and taper it down as the edema reduces. Of course, oral Diamox also may have to be given if intraocular pressure is high. So these are the 3, 4 medications which we give systemically.
Also, madam, sometimes we get patients who have total epithelial defect in chemical injuries. We
Yes.
start all the medication. They initially respond very well, and later on, once the epithelial defect is almost 70% healed, and then they are not responding to that medication. So at that time, is it a good idea to again scrape the epithelium, or should we consider reducing the steroids?
Yes, so this is also a very good question. First thing is to reduce the steroids at this stage, and something that we don't use very much. See, many are tempted to just put a bandage contact lens, but a bandage contact lens prevents further cell loss, but it may not aid the healing, because when it becomes a non-healing, that means the edge is not migrating. That means those cells have stopped migrating. So if you put a lens, it's not going to migrate. What you have to do is, with anesthesia, with a 15 number blade, you gently pull the edges down. Many times, no, you will find that actually the epithelium has grown, but it keeps retracting with the lid movement. So with a 15 number, as you gently pull it down, you will find that 1 or 2 millimeters it will extend. Then you would roughen it a little bit, and I do a pressure patch.
Oh.
In my practice, I feel a pressure patch works better than bandage contact lens. So you put antibiotic drops, put cycloplegic, you freshen the edges, pull whatever loose epithelium to as low as possible. Then I fold an iPad double, fold it in half, because otherwise it doesn't fit the hollow. And then you take a micropore tape. You need 2 people to do this. You press the patch down, and the second person stretches the micropore and presses it down on the cheek and the brow. And then you repeat 5 to 6 tapes. And I feel, one, it gives comfort. Two, the epithelialization is very good. Once it is epithelialized, then you put a bandage contact lens to prevent it from breaking down again. And now we are using also insulin eye drops to aid the healing. So if you're very sure there is no infection, you pressure patch. Once it heals, you put bandage lens. But if in spite of pressure patching it doesn't help, then you can use topical insulin. You get Actrapid 40 units per ml. You take about anywhere from 0.4 to 0.6 ml. You add it to artificial tears and you give it QID. So it helps epithelialization. It helps the nerves also to grow in. And there are enough studies to show that the epithelialization in a clean, non-healing ulcer, where there is no infection, it will aid the healing much faster.
there were few questions, total cell loss and how to prevent symblepharon.
Right, sir. So, total limbal cell loss we can see if now sometimes when the patient comes, he looks like a grade 5 where there is no limbus at all. But you just watch for 1 or 2 days. If you see some limbal cells growing, then this will epithelize the surface. And that is where you have to keep a watch. If the conjunctiva is growing and the epithelium is sliding, just keep pushing that conjunctiva back. So that way you can get, even if suppose there's a small 2 millimeter by 1 millimeter block of epithelium remaining, which has this viable stem cell that has the ability to repopulate the whole ocular surface. But if you have limbal ischemia, then that will be 100% limbal cell knockoff. And in that case, we have to do a limbal cell transplant after the ocular surface has stabilized. As
Yes,
far as
and
preventing the symblepharon goes,
yes,
I think the acute phase, it is very important to keep a very frequent follow-up, and simple things like just sweeping the fornixes with a sterile bud with applicap, or earlier they used to teach us the thermometer, back of the thermometer, you disinfect with spirit. But then we stopped doing that once the sterile, when I was a student, there were no earbuds. आम्ही वाती बनवायचो out of cotton. Or you make pellets, hold with a forceps, and then you had to sweep it. We did not have ready-made earbuds and spears and any of that. So that's why the teaching was either you use a sterile muscle hook or you use the back of a thermometer. So if you sweep, then you can prevent the adhesion. Then I also said, like this last little girl, if you see, it's like a pterygium growing, no? You can inject 5-FU. It prevents the vessels from growing, makes it less aggressive, and then it will also make it atrophic. And finally, if you have a established symblepharon, then you have to do a symblepharon release, do a conjunctival autograft from same eye or using the other eye. Or we have also in very severe where you have too much tightening, you cannot mobilize conjunctiva. Sometimes the parents or patient will just refuse the other eye to be touched. You can even use buccal mucosa as a barrier. Once you release the symblepharon, you remove all the fibrous tissue from below, retract it to line the fornix or the lid, and the remaining part you can put buccal mucosa. So that also works. And then many times during a corneal graft, if suppose like it's a small child and you're not sure of how the bed is, you don't want to take a limbal cell from the other eye, we use the donor itself, the donor rim, you can split it into a lamellar section and you can apply it as a bridge all around. So your center is a full thickness graft. When we do penetrating keratoplasty in these patients of following chemical injuries, the residual bed is very, very thin. And we will do a full thickness graft when the bed is
noted.
opaque or cloudy. So you cannot do a dull. So when you do that, you have a very thin rim because you have removed all the symblepharon or done peritomy, and then you have a very thin host bed, and then you're doing a full thickness graft. So you take the remaining rim of the tissue, donor tissue, slice it very thin and place it all around. So you have donor limbal cells and the same donor, and you're anyway going to immunosuppress either with oral steroid or local steroid. And that works very well as a barrier to prevent the symblepharon from growing back onto the cornea. So these are the few things you can do. But again, symblepharon release, once it is formed, let it mature. Because if you do in a progressive symblepharon, it's going to start forming all over again. So let the scarring be complete. And then once and for all, you can do the symblepharon release with either
Noted.
mucosal graft or a conjunctival.
It's 21:25. We are running short of time.
Last
There
five.
There
Any
is
other
one.
question?
There is one question from audience.
Yes.
The pathology. What is the pathology or mechanism of rise in IOP in cases of chemical injury?
Yeah, I think I explained that in a couple of slides. The first immediate one is acute shrinkage of the collagen tissue, which causes tightening as well as the trabecular meshwork. So the scleral ring itself gets tight and that will cause a rise in pressure. Again, if you have penetration of the chemical into the anterior chamber and a fibrinous response, then all that fibrin is going to block the trabecular meshwork. And finally, the scarring inside the trabecular meshwork can also cause a late secondary glaucoma.
There is another one question from audience. Many times the patient comes with firecracker injury, debris get remained in stroma or subepithelium, and which will not get removed after eye wash. Also, many epithelial debris get formed. Should we scrape or debride with a cotton tipped applicator?
So if there is any penetration into the stroma, just leave it alone. You can see an explosive or blast injuries also, little bits of metal. And most of these are inert, and because it is at such high temperature, these are kind of sterile, you can consider them. And unless it is iron which is going to cause cirrhosis, you can safely leave these alone in play. So don't go aggressive and keep cutting up the superficial layers to remove the debris. So these can safely remain, and they'll remain for many decades to come.
Sitafal bee, that is custard apple seed injury, is also very common in remote areas also.
Very dangerous, very dangerous. They use it for lice and then they'll put it in the hair, keep it, and when they're washing it, it goes into the eyes and it causes very severe injuries.
Yes, ma'am. I want to ask you another question, ma'am, which is the extension of Dr. Kanade's question. What is the most common mistake you usually observe a general ophthalmologist make while managing chemical injuries?
Nice.
So I don't remember any such mistake that has come to me. I think
Nice question.
only one thing is, sometimes you get this discoloration, or they may end up with a secondary infection, and if you miss that point of the complication and you continue the steroids, then you will end up in disaster. Or if there's a delay in referring the patient when a scleral melt has already started, he may just come, like I showed one, no, where the iris had started coming out. So, when you feel that this patient is not getting better or is getting worse, or that sclera is looking white and blanched, just send the patient to somebody who can handle.
Timely referral is very
Timely
important.
referral is important, and keep a watch for secondary infection. That is the main. Thank you so much. I think it was very interactive.
Thank you, madam.
Thank you.
Very happy to take.
Thank you, madam. Our participants are interested in your second session also in coming next future webinar series. We will again invite you for different subject. Okay.
Thank you so much.
Thank you.
Thank you. Thank you, madam.
Thank you.
Dr. Nutan?